right, welcome everyone. In today's high-yield explainer, we're going to master mycetoma. This is an absolutely must-know topic for your pathology exams. We're going to break it down, focusing on the key comparisons and memory tricks you need to just ace any question that comes your way. Okay, let's just dive right in. Picture this. A patient, maybe a farmer, someone who works barefoot a lot, comes into your clinic with a foot that looks like this. Chronically swollen, totally disfigured. This classic picture is called Madura foot, and it's pretty much the poster child for mycetoma.
So what exactly is mycetoma? Well, the definition itself gives you the 3 key words you need to remember for your Viva exams. It's chronic, it's slowly progressive, and it's a granulomatous infection. That just means the body is trying its best to wall off the infection with immune cells. It kicks off in the skin and the fatty tissue right underneath, but don't be fooled. It can dig way deeper. Now, for your exams, you have to lock in this clinical triad. The mnemonic is super simple. TDS. T is for tumefaction, which is that massive tumor-like swelling. D and S stand for discharging sinuses. These are little openings on the skin that are just oozing fluid. And that last S? That's for the granules you find inside that discharge. TDS, super easy to remember, super high yield.
So here's our game plan. We're going to cover the basics, figure out who the main culprits are, see how it all happens, and then, most importantly, get into the diagnosis and treatment. So let's get started with the 2 main culprits you absolutely have to know.
Now, here's where it gets really interesting. See, mycetoma isn't just one disease. It's a clinical syndrome that can be caused by 2 totally different types of organisms. And telling them apart, well, that's the key to everything. This is probably the most critical distinction you need to make. Eumycetoma is fungal, caused by true fungi. But Actinomycetoma, that's bacterial, caused by these weird filamentous bacteria like Nocardia. Now, the bacterial form is a bit more common worldwide, but this one single difference, fungus versus bacterium, is going to dictate everything that follows, from how you diagnose it to how you treat it.
So, how do you even begin to tell them apart? Well, you look at the granules. The color of the stuff coming out of those sinuses is a huge clue. If you see black granules in a question stem, your brain needs to immediately scream fungus, specifically Madura mycetomatis. White or yellow granules? Could be either. But red granules? That points you straight to a bacterial cause, Actinomadura pelletieri.
So how does this whole mess even get started? First off, it's not contagious, so you can't catch it from someone. The story almost always begins with a simple, unfortunate accident, a tiny injury that lets the bad guy in. Let's see how that unfolds. The whole process is actually a pretty straightforward 3-step story. First, you have inoculation. The fungus or bacteria is just chilling in the soil and it gets jabbed into the tissue, usually by something like a thorn prick. Second, you get an initial reaction where a small abscess forms. And finally, the body tries to wall off the infection, which leads to that chronic, walled-off granulomatous stage that we see in the clinic.
Okay, let's get to the real heart of this for your practicals and your MCQs, the diagnosis. How do you prove, without a shadow of a doubt, what you're dealing with?
This table is fantastic because it lays out the clinical differences you need to be looking for. The fungal kind, Eumycetoma, it's usually more contained. Think a single swelling, fewer sinuses that show up late. But the bacterial kind, Actinomycetoma, is way more aggressive. You'll see multiple masses, tons of sinuses popping up early. And the big one, look at the bone lesions on an X-ray. The bacterial form is osteolytic. It literally destroys bone. The fungal form, on the other hand, is often osteosclerotic, meaning it makes the bone thicker. So yeah, the clinical signs give you some really strong clues, but they're not enough for a definitive diagnosis. To figure out the treatment, you have to get a sample. The real answer, the smoking gun, is hidden inside those granules when you get them under a microscope. And here it is. This is the money shot for your exams. This is what you're going to see. On the left, for Eumycetoma, you've got these thick, broad fungal hyphae. They're more than 2 micrometers wide. But on the right, for Actinomycetoma, you see these fine, really delicate filamentous bacteria. They're much, much thinner, less than 2 micrometers. That size difference, it's a dead giveaway. So the key here is to follow a logical lab workflow. You collect the granules, you wash them, and then, based on what you already suspect, you use the right tools. Think it's fungus? Use a potassium hydroxide or KOH mount. Suspect bacteria? Do a gram stain. And you gotta remember this, if you're thinking it might be Nocardia, you have to do a modified acid fast stain.
All right, so we've correctly identified the culprit. Now what? How do we treat it? This is another super critical area of comparison, and you guessed it, a favorite exam question. Treatment is, well, it's not simple. It's almost always a combo approach. First, surgery is often needed to go in and just remove as much of the infected gunk as possible. And that's followed by a very, very long course of medication.
And this slide right here is why getting that initial diagnosis right is so absolutely vital. You cannot mix these up. You treat the fungal cause, Eumycetoma, with long-term antifungals like itraconazole. You treat the bacterial cause, Actinomycetoma, with antibiotics. The most famous combo is the Welsh regimen, which is amikacin plus cotrimoxazole. Totally different drugs for totally different organisms. You know, since the infection gets in through some kind of trauma, prevention is really just common sense, especially for folks in areas where this is common. Wear proper shoes, and if you do get a puncture wound, clean it out really well right away. Okay, team, we have covered a ton of ground. Let's pull everything we've learned together into one final super high-yield revision slide. You're going to want to get ready to screenshot this one. And there it is. This beautiful table summarizes all the key comparative points you need. Agent, fungus versus bacteria. Granules, think black versus red or yellow. The clinical course, slow versus aggressive. Bone lesions, sclerotic versus lytic. Microscopy, thick versus thin. And treatment, antifungal versus antibiotic. If you can master this table, you've mastered mycetoma. So the crucial takeaway here is this. Always, always think fungal versus bacterial. The entire management plan hinges on that one distinction. So as you go back over your notes, think about this question. Which type has a worse prognosis and why? Think about how fast it progresses and what it does to the bone. We'll see you in the next explainer where we're going to tackle sporotrichosis.